Good evening, and welcome to another edition of the Rankin Mon Valley Greater Pittsburgh section of the National Council of Negro Women. My name is Patricia Bluett, and I am the section's corresponding secretary. And joining me today is Alice Paylor Days, who is the section political committee, one of the section's political committee members. We thank all of you who have participated in our previous programs, and we hope that you will join us again today by calling 412 953 9583. That number will remain at the bottom of the screen. Our special guest today is Dr. William Simmons, who will again help us to discuss the COVID-19 virus and the vaccination. This program satisfies two of our national mandates: to disseminate information about issues affecting African American women and their families, as well as promoting healthy lifestyles and behaviors through wellness projects. It also satisfies one of our Four for the Future initiatives, which is to continue National Council of Negro Women's historical focus on health concerns in the African American community. Alice?
Yes. Good evening, Dr. Simmons, and welcome to another segment of the National Council of Negro Women. And we're glad to have you with us this evening. And we're about to start the show. Yes, we're glad to have you back with us this evening. And I understand that you will be speaking with us about the COVID epidemic that has hit us. You'll be explaining your involvement with that.
Well, yes, but the first thing that I'd like to do is there's always been some weariness of African Americans along with the medical establishment. And
Yes.
I wanted to go through, since it's barely past Black History Month, I wanted to go through a little bit of the history of the involvement of Blacks and the medical establishment and show how this has evolved. And just to give some information about that, but we'll also then segue into talking about the most recent concerns around COVID. But I think it's very important to have a good picture of how Blacks, how this hesitancy toward what vaccines and so forth actually got started.
Yes. So you're going.
Okay, I guess we're starting that talk right now, and
Yes.
For those who may not be aware, I'm an associate professor at the University of Pittsburgh School of Medicine, and one of the attending anesthesiologists and critical care docs. I'd like to, and we're going to our next slide. You will see the history that in 1721 there was a smallpox epidemic that came from South America, but the ships that were coming into the Boston area was bringing the smallpox with it, and it infected the entire. It just went through Boston like wildfire, and many people were dying. Many people became very sick. We can go on to the next slide. And this was a major problem with this smallpox. But the thing that I wanted to bring up with this is that even back then there was no such thing as a vaccine. But the first people who actually ever received a vaccine in the United States were African Americans. There was a doctor Dr. Mather, who was in the Boston area, he actually had a black slave who was an educated man. He probably was a physician in his own right. What people don't understand is that the slaves that were taken from Africa, not all of them were just some of the people were well educated. And this particular slave that was with Dr. Mather was well educated. And he said, you know, when we had this problem in Africa, we used to give a small inoculation of the infected thing that was causing the sickness, and that would gives a type of immunity to the people in the village. And so Dr. Mather took that idea, and he was able to isolate a sample of the smallpox and use that as an inoculant. And he first tried it on 6 or 7 of his slaves. So blacks were the first ones to ever receive an inoculation or so-called vaccine in the United States. And since it seemed to work well, and these slaves were never got problems with the smallpox, he then, after some time, tried it out on whites, and it actually turned the tide on the problems that were going on with smallpox back in 1721. So going on to the next slide, you can see a picture of this particular slave. You notice that he was the one that gave the suggestion to the doctor at that time. And it said this slave curbed the smallpox epidemic in Boston in 1721 with an African technique. And this African technique, which is inoculating with a small amount of the affected area, so that you might get a little sick, but you won't get as sick as you would have as you got the full blown. Let's go on to the next slide. Now, this one here is a little bit more bothersome. During the time of Dr. J. Marion Sims, this was in the 1800s. He was and is considered the father of OBGYN surgery. That's the women's surgery. But the thing was that while he was developing his techniques, he would do his surgery on black women, slave women, without anesthesia. And then after he got it perfected, he would do the surgery on white women with anesthesia. These women were tortured. These women went through surgery with no anesthetic whatsoever. But his techniques that he developed have now become widely accepted by the medical community, but no one seems to remember the horrible history that was associated with how his techniques were developed. Going on to the next slide, you can see one of these statues of the James Marion Sims. They're in many different places where he is touted as the father of gynecological surgery, but the kinds of things that he did to black women to get his skills were just tremendous. Going on to the next slide, you can see that we also had other kinds of barriers that caused us some problems there was the eugenics crusade that went on and this was in the late 1890s. This eugenics, this was a part of basically saying that white is right. They were trying to say that, that the blonde-haired, blue-eyed child, they were perfect, and they would consider and lump black people and black kids and in with the handicaps and everything as being a lesser being. One of the people that was very much involved in the eugenics crises, or the crusades, should I say, was Margaret Sanger. Margaret Sanger is the woman who actually came about and started the abortion clinics that are available. But notice, if you actually notice throughout the country, most of these abortion clinics are bordering Black neighborhoods. Go on to the next one, the next slide. You can see there was statements that were said, that was copied and put in a newspaper, that talked about how Sanger actually had implied that they were trying to utilizing these techniques to reduce the Black population. But in any case, other things that were going on that was just problematic is that when Black women used to go into some hospitals in the South, without their consent, there would be situations where their uteruses were taken out. It was done so frequently in Mississippi that it was called the Mississippi appendectomy. But they were not taking out the appendix. They were actually sterilizing Black women by taking out their uteruses without their consent, and they never really knew that it happened. They would just try to conceive or have children in the future, and found out that they could not. Next slide. There were, when I grew up in South Carolina, the young kids, myself included, were not allowed to go out at night. And the way that the grown-ups would say it is that, oh, you can't go outside, the boogeyman will get you. And we always blew that off and say, oh, they're just making fun. But here late, I found out that there truly was a boogeyman. Apparently, during the time in the 1900s, particularly, a lot of the white schools and some of the prominent ones universities and white medical schools, they needed bodies, cadavers to do for their students to learn on. And so they would send out people that would go out into the back countries, into the Black areas particularly, and they would initially try to take the bodies from fresh graves, and they were stealing these bodies. However, when Blacks caught on to that and started putting grids over some of the graves so that they would not be able to get to them while they were fresh, they started stealing people off the street. So that means if you were a Black person, a Black man or woman, and you were walking down the side of the road by yourself late in the evening, and these people were driving by, no one would ever see you again. Next slide. Now, of course, everyone has some idea about what went on with the Tuskegee experiment, and that was with in intentionally not treating Black males that had syphilis. The syphilis problem was a very big problem during that time, and the reason that these people could get away with it is that they were just trying to, so many hundreds of thousands of soldiers, when they went off into World War II and they went to Europe and Italy and so forth, they would meet women in those areas, and these women would oftentimes have syphilis or gonorrhea, and that actually wasn't, they didn't have any treatment at the time. So soldiers would be out of action for 6 months to a year, depending on what kind of treatment that they have to get. They were giving iodine and all kinds of strange concoctions, but it took a long time to heal, for them to get better. Well, so the studies that they were doing was that they wanted to see the long-term effect of syphilis on a population, and they happened to choose this Black group of soldiers that came back with syphilis, and they would not treat them. And they, even when penicillin came along, they still wouldn't treat these particular ones. They'd keep them isolated and away from treatments that were available. If you go on to the next slide, you'll see that, as I was saying, that penicillin did become available, and you go to the next slide. But Mrs. Eunice Verdell Rivers, and there was a movie out called Evers Boys. This is her name, true name was Rivers, but she was the one who was the intermediate that would be talking to these people that they were trying to keep them away from penicillin and actually see what the long-term effect of syphilis would be on a population. But the thing is, these men would give it to the women that they were associated with, and their children would be born with syphilis, and this would be going on generations. And this went on for 40 years. And but the main intervening person was a Black woman who was a nurse that basically ran the program against these men. Next slide. Now the thing is, while they were doing that, what people don't know is that the same group of doctors that were doing the Tuskegee experiment also went to Terre Haute, Indiana, to the prison there, because they needed to have additional subjects for the syphilis study that they were doing. And so they went into the prison system there and took patients and inoculated them braised pieces of their body, a penis on their leg, and exposed them to syphilis and to gonorrhea, and tried to get as many of them infected so that they can study these patients as well. Next slide. So this is a scene where they are intentionally inoculating a prisoner's penis with syphilis in the prison. The problem is it didn't work as well as they wanted it to, because what they needed was the natural way of a sexual act to have that done. And of course, like in every other state, prostitution wasn't legal in Indiana, so they could not get prostitutes to go into the prison so that they could inoculate them. So what they found out is that, in the next slide, they found out that in Guatemala, one of their graduate students was from Guatemala, and he recommended that the team go down to Guatemala because prostitution was legal in Guatemala. So this team, another part of the same people that did the Tuskegee experiment on Blacks, went down to Guatemala, and you can go on to the next slide. And what they did was they organized the sex workers and decided or pretended that they were giving them health care so that they can find out which ones had syphilis and which one didn't. And when they found ones that had syphilis, instead of treating them, they super inoculated them so that they can truly be contagious, and sent them to the prison system in Guatemala. And you go to the next slide. And they also sent them to the soldiers. So they deliberately infected soldiers, the prisoners, and the mentally ill with syphilis and gonorrhea, just so that they could study it. And they did it without letting anyone know that they were doing this. Next slide. This is the prostitutes in Guatemala prisons exposed about 770 people to gonorrhea. The next one. And in the psychiatric ward, these patients, they also exposed them manually to various kinds of things so that they can see how these people would survive. Next slide. And so 446 psychiatric patients were intentionally exposed to syphilis. 71 of them died during the experiment. And the thing was, now, Dr. Perron, who was the Attorney General at the time, covered for all of these kinds of things. The Tuskegee experiment, the ones at Terre Haute, Indiana, and the things that were going on in Guatemala. He covered for it and didn't let anybody stop it. But when he no longer was the Attorney General, they immediately had to stop the experiment. Next slide. They had to stop the experiment, and they all left Guatemala, and they didn't treat anyone, even the people that they super infected and so forth. They didn't treat them. That's why a lot of medical missionary groups go down to Guatemala, orthopedic groups, because these people are still suffering from tertiary syphilis symptoms because of what was started back then and never treated. Dr. Perron went to the University of Pittsburgh and became the first dean at the University of Pittsburgh in one of the departments there. In the next slide. And Dr. Cutler, he was the guy that actually was down in Guatemala, and he was a part of the study in the Tuskegee experiment. He became a part of the dean of the public health at the University of Pittsburgh. Both of them were at the University of Pittsburgh. On one more slide, please. And so the other person of note that you should actually know about is Henrietta Lacks. Henrietta Lacks in 1951 was a 31-year-old African-American woman who was being treated at Johns Hopkins because she had a very, very aggressive kind of cervical cancer. But unlike everybody else that they were working with at the time, they would try to isolate the cells from a biopsy that they would take, and these cells would not react well in the laboratory. They would die very quickly, and so they couldn't use them for future study. However, Henrietta Lacks' cell was essentially was immortal. They didn't die. They were able to use them for experiments. Matter of fact, industry, the chemical, a lot of the pharmaceutical companies and all of these have used Henrietta Lacks' cells to make their chemotherapy drugs, their other drugs, getting billions and billions of dollars, and the Lacks family got nothing. So this was a situation where they recently tried to come back against some of the schools and the researchers that have utilized this family's cell line from Henrietta Lacks, but they still use her cells, and they are called HeLoc cells, which is short for Henrietta Lacks. HeLoc cells are still being used in research throughout the country. Next slide, please. So one of the things that I wanted to just kind of emphasize, so you get the full picture. Yes, we have lots of issues associated with being mistreated, but the mistreatment did not stop with that. The mistreatment went on to the fact that we did not have good access to medical care. And because of the poor access to medical care and other problems, we became very much targets for problems. If you look at the slides that you see here, prostate cancer, African Americans, the purple one, we have the highest incidence of death associated with prostate cancer. If you look at colorectal and colon cancer, again, African Americans are #1 in death rate. Diabetes, we are the #1 with problems with diabetes. And HIV. HIV started off with white male gay population, and it soon transformed into a Black disease. And so throughout, even though they don't talk about it very much anymore, there are thousands and thousands of people who are walking around either in a carrier state or with the full-blown AIDS, and they are African Americans and dying because of it in large numbers. But all of a sudden, it's no longer a white male disease, so it's no longer something that people talk about. They used to talk about it all the time. Next slide. As far as heart disease, again, African Americans have the highest death rate associated with heart disease, cancers of all kinds. But the one unusual thing that I wanted to bring up with this audience of women is that breast cancer, white women had the highest incidence of breast cancer, but Black women had the highest death rate, which is a sign of access, which means that people may have not had medical access, so they took them longer to go to a doctor when they had a problem. So our experiences with the medical community and access to medicine has been a long and tumultuous problem. Next slide, please. And now I am transitioning into COVID, but I wanted, but that was that I felt that what we had talked about was important to let you know, just to give you a background as to people were wondering, okay, why are African Americans so leery about this or leery about that, or don't want to volunteer for this study or that study, the other thing. We've been volunteered enough in our history. This new generation of vaccines that we have, again, the RNA prototyped vaccine, and that is what's being used here for the COVID-19. The vaccine did not get studied like the normal vaccines. There wasn't animal studies that were done on this. There wasn't a outcome analysis looking at kinds of wellness or problems that can occur health-wise. There was no long-term studies that might say what might happen if you do this drug, and what can happen in a while. So those kinds of things were all cut out, and most of the studies are now being done on basically by watching and seeing what happens to us to see if there's any long-term associated problems. The line is the statement is that, of course, that there is none, but right now there hasn't been any studies done to prove whether we have any problems or not. Next slide. This is for those who hear about it but never seen one, kind of a dramatic look of what a COVID, what the virus looks like with the protein when they call them out, when they talk about having these stipules or the protein on the surface. This is kind of what it looks like. Next slide. So all viruses are associated with these, all viruses have associated with them these surface proteins. And these surface proteins are the ones that actually are the ones that actually interact with our bodies, that cause antibodies to be created. And those antibodies are the ones that try to protect us in the long run. The messenger RNA technique, in this case, we are using messenger RNA so that we can create or make the fragment codes that we can make our bodies to make antibodies. So we become the factory to make the antibodies so that we can fight off the COVID. And so the RNA technique that we are using, it does not use as a pathogen. Oftentimes the the way that we did it in the past, that they would use either live viruses or recently dead viruses as a way of stimulating antibodies production. Here they're delivering a fragment code of RNA, and that fragment code will go and stimulate in the body, has to go into the nucleus and it gets incorporated, and from that we make antibodies. Next slide. The fragments of the codes, they need, because of the fact that when we're trying to go into the cell themselves, trying to go through the cell wall and into the nucleus, these fragments of codes can be damaged. So they cover them in a lipid nanoparticle, which kind of like a suitcase that they put them in so that they can get to where they need to go without being damaged. And that's what people talk about. They're using nanoparticles, but that's what those are, just as a carrier, so that the RNA that they're trying to get introduce into our body does not get damaged. Next. And then when we are talking about the gene therapy, they were talking about 95% effective. I just wanted to make sure everyone understands that was 95% effective of attenuating the symptoms in the first variant. As you know, we have had multiple different variants so far. We've had, and they don't even tell us all of the ones that go by. We've jumped from the first variant to the Delta variant, which is like 4 down the line. And then we got the Omicron, which is like 12 down the line, and so forth. So in any case, we have different variants. And as we go from one variant to another, we start having a situation where they don't necessarily have the same effectiveness with the vaccine as the first variant did. So and no one's actually been studying excessively to find out if indeed what degree. Matter of fact, they were talking about the Omicron not being as effective, the vaccine not being as effective against the Omicron, because it structurally looks different, it functions different, and it's a little bit more virulent, meaning that people caught it much faster, but they didn't have as worse symptoms and outcome as they did with Delta. Delta people, a lot of people died. A lot of people had long-term problems. A lot of people had brain fog and a lot of associated problems that made them tired for long periods of time. The Omicron is not nearly as problematic as that. Next slide, please. The antibody testing, we test for IgM and for IgG, and that's by looking for, when we're looking for the IgM, we're looking for long-term, whether it has happened to us in the past. So an IgG is more an acute process. So we try to figure out whether this person, and so they do it by the quick test, or they do it by looking at the immunoglobulins to find out one way or the other. So there are many different tests that people use, and there are many of these quick tests that are not nearly as accurate as some of the lab tests that you can send off for, but indeed they do give you an indication. Next slide, please. The Delta variant spread more easily than the previous variant, and the thing is that we were finding that even people who were already vaccinated, you may not be affected, but you might still have some virus in you that you could still spread. So a lot of people were wondering about whether you could still spread it even though you were not affected by it to a great degree. Yes, people who had had both of their vaccines or whatever may not be affected by it, but you could still spread it to other people. Next. This is kind of a look at how you can see how different the Omicron looks compared to the ones that I showed you in the past. And this is its surface proteins are a whole lot different, and so they don't even know how this got created, because it is so structurally different from the ones that came before. And so basically, and that's basically all. We don't that we will go. We'll go to some questions, or we will go to discussions from this point. Okay.
Okay. Very good. My first question to you is the experiments that you spoke about. How were the experiments financed?
What experiments? Which ones you're talking about?
The medical experiments.
Okay, I'm saying that in the circumstances of
They did the syphilis experiment.
Oh, the syphilis experiment.
Yeah, how was that financed?
The Attorney General okayed it. Our government paid for it.
Mm. Mm, mm, mm.
Huh? This was a sanctioned government experiment.
When you talked about the Henrietta Lacks cells, so her cells never died.
Because of her cells were being able to other cells, when they tried to put them in storage so that they could use them at other dates, they would not survive. Henrietta Lacks cells, on the other side, not only was able to survive, but they matured, they spread, they were able to give some to other people, so they ended up all over the world.
So was it ever determined why her cells never died?
I don't think that was one of the. I don't know if they had a good reason for explaining why it was, but because they had those cells, they were able to use them in experiments and came up with all of the chemotherapy treatments that you hear about now, all of the and a lot of the medicines that you hear about now. All of that was done on the human cells. Studies were done, a lot of them with Henrietta Lacks cells.
Why do you think her cells didn't die? What's your medical?
I actually don't know. She had a fairly good genetic profile that made that, and I don't know if it happened again, meaning they kept using her cells. It wasn't like it was somebody else's cells that they could just readily go to. So it's just her. She was very unique.
Mm.
And also you mentioned something about foreign protein. What is that?
Foreign
protein.
I'm trying to remember what context that I mentioned that in.
Well, my other question though is when you stated that our bodies make antibiotics, right?
Antibodies, yes.
And does our diet have an impact on that?
Our diet has an impact on every aspect of our life. I got to tell you, and our diet has an impact on how well we can protect ourselves, because having the right amount of vitamins and minerals and things that are essential for your bodies to make the cells and for it to grow is so. Having good nutrition is an essential part of good health, and that's and that is, and so those people who were trying to avoid taking a lot of medicines and so forth, they would readily tell you that they didn't get sick because they had a lot of vitamin C, they had a lot of vitamin D, and one of the problems that African American has is because we don't get a lot of vitamin D. We don't. The darkness of our skin is more of a repellent to the sunlight acquired vitamin D, and so in the wintertime particularly, our levels go down very low. What is a problem is that the immunological system in our body requires vitamin D to mount a defense and fight off of bacteria and viruses. So many African Americans preferentially was dying from COVID when they went into the hospital. And if they took vitamin D levels on these people, and they should be around 50 UI, which is international units, they were 5. They were very low. And
Okay, we have a caller on the line. Mark,
Mhm.
you have a question for the doctor?
Yes, Miss Pat and Alice, it's always good to see the both of you, and thank you again for another great show.
Mm-hmm.
Dr. Simmons, it's always good to see you on the case here. I really, for the first time, I really don't even have a question. I just called to say, doctor, your 25-minute presentation, had that information been available 12 months ago when this whole marketing campaign of forcing people to take the vaccination, I think it would have explained a lot of the hesitancy that African Americans had. I did not get it, but still today, I cannot talk about it even at family gatherings because they believe I'm the spreader, because I didn't get it and because of the propaganda that was used. So it's just wonderful information, doctor. And I just called to say thank you very much, and I'm going to continue to listen to the show. Thank you.
Okay.
Thank you, Mark.
Mm-hmm.
Yeah. Okay. And Dr. Simmons, what about children? What age should children get the vaccination? If they get it, what age should they start?
Can I tell you that because I'm even though my training or what I do at University of Pittsburgh is I'm an anesthesiologist. I also am a trained. I was the first Black chief resident of pediatrics at Georgetown Hospital in Washington D.C. and so I'm fully trained pediatrician as well as an anesthesiologist.
Mm-hmm.
And I have some reservations in the shot for kids, and that's why I might not be the best advocate of that. My problem is that kids don't really get that sick, or they don't get sick very from COVID itself. They get maybe down for a little while. I don't know what these vaccine is doing in the long run in the children. So I would say that I'm more in tune with doing these for 11 years old and up, and teenagers and but when you talk about giving it to 5-year-olds and so forth, I have some hesitancy in my own mind about that. Right? And so that's only my own personal opinion. That is not. So I'd say 11 years old and above is when we should be doing that, because they are more grown. They can tolerate it. These younger ones are just forming, and I don't know what this RNA virus thing is going to do to them. I don't want to see a long-term process just being experimented, finding out when they become 25 and can't have kids. I'm sorry. I'm not interested in doing it that young.
Okay.
Now, I have a question for you. Over the past 2 years, what have we learned regarding the viruses? And what are the things that we should be doing and the things that we should not be doing? And I want to piggyback on that last question that you were asked. The children may not have a devastating effect on them. The virus may not have that. But what about the adults that are around them, like in the schools and their parents?
Absolutely. The kids themselves may not be a problem, but the kids can carry it and carry it to their grandparents and carry it to their teachers and so forth like that. And I guess that's where the problem is. If we're just talking about the kids themselves, they don't get affected very much, but they can be a harbinger and a spreader. And I just wanted to make sure that everyone understands, even if you got the shot, you can spread the virus. You may not get affected by it, but you can spread it just as a person who doesn't have the shot can spread it. So the concept of trying to make a person who didn't get the shot feel like they are evil is there's no sense in that because they both spread it. That's but so I'd say the kids are not as affected, but yes, ma'am, you're completely right. That child coming in from school, hugging their grandmother, hugging their grandfather, can indeed be a situation because the elderly people are truly more affected and more susceptible and can have more problems. So yes, but I would say 11-year-old and above would be a better age to give a vaccine to. The 5, 4, and those younger kids, I'm concerned about that.
Mm-hmm. Now, Dr. Simmons, has it been determined where did the virus come from, or what is the cause of it? Where did it start? How did it get here? How did it get in our community?
That's an unknown. Many times, if you when you look at viruses that are in the population and so forth, you can go to the blood bank and isolate blood. You can isolate antibodies to that virus, whatever that's coming along, because it's been in the system for a while. Unfortunately, when they went and tried to isolate the COVID virus from any kind of blood bank samples, meaning has it been around for a while? It is a brand new occurrence. It is not. It has not been around. It didn't evolve from anything. It was just one day it was there, and so I don't know where it comes from.
Some people have gotten all of the shots, have gotten their shots, have gotten their boosters, but we still have a very large number of people that are still getting the virus, even the ones that have their vaccinations. What is it that we need to do to stop this virus?
That is not, unfortunately, we don't have a simple answer to that one either. The thing about viruses is that they transform, they change, and this is a worldwide situation. So in some segment of Africa, or some place in India, or someplace in some place, this virus could go through some kind of transformation, and all of a sudden, by summer, you got a new name and a new virus coming back around. So because of that characteristic of these kinds of viruses, the fact that they change, mutate, the treatment that you create for the first one doesn't necessarily mean that it's going to be as effective for the second, third, fourth, and the fifth or sixth rendition of that virus. And that's why Omicron is not the vaccine is really good at the first one, but it isn't nearly as good as the ones that came after it. And so we don't know. We are still not had a lot of research done as to find out what's going on and how we're still in the dark. I'm sorry.
So if we don't know where it comes from or how it surfaces, how do they determine or come up with a vaccine for it?
Well, they may not know where it came from, but the vaccine is a product of the surface proteins on the virus. And so what they're doing is they study the virus itself. They try to create a situation that can create antibodies to the surface proteins.
Okay.
So that so it is the experiments are done directly on the virus itself. It doesn't necessarily are trying to track it through history.
Okay, we have another caller on the line. Valerie, you're on the line.
Great presentation, particularly about the early vaccines that were given without awareness. My current question is there's still a great deal of debate about wearing masks, whether it's an N95 or other masks. I know when I was recently in the doctor's office, they said, no, we were told not to wear N95. So my question to you, should I continue to wear my mask? Should children in settings wear masks to protect the elderly? And I guess there won't be a time when we should not be wearing masks where we're in a large setting. I'll hang up, but thank you so much in advance for your response.
I definitely think that the masks can and will be with us for a long time. Especially in larger groups, there is some controversy as to which kind of mask. For a while, we didn't even have the N95 mask in great supply, and places had to try to get them, and we were using them in the hospital. I'm in the operating room, and we often never even knew if the patient that we did an emergency surgery found out afterwards that they had COVID. So we had to wear N95s because we had to treat everybody like they had COVID. As far as whether you should be using those, I would say in normal activities and normal way of life, you may not necessarily need something that has the millipore size of an N95 kind of mask. Just a regular mask will do. I think that they are going to become a lot more lax, as you can see from just going to the grocery store, or going to the gas station, or going places. People are because they're vaccinated, they are deciding to use masks less and less. But I would definitely think if you are around people who are immunosuppressed, if you are around people who are elderly, if you are around people who have chronic illnesses and are susceptible to, you may want to, continue wearing your mask to protect them from any potential things that you can give them, because those patients and those people are the ones who are truly susceptible and can be harmed greatly.
Okay, we have another caller on the line. Lori is on the line.
Hi, everyone. I think this is an excellent show. Thank you for having it, and thank you, Dr. Simmons. I would just like to ask, when patients are in the hospital with COVID and the ones who do not or are not vaccinated, are they treated differently than the ones that are vaccinated? I am going to hang up and listen to your question. I'm just concerned about that issue. Thank you. Bye.
When you're coming to a hospital and say you are having elective surgery, one of the questions that they will ask you is, have you been vaccinated? And if you are not vaccinated, your surgery could be delayed. And because and so yes, people who are not vaccinated are treated differently. And there is, however, if people who are in life-threatening situation, that's not the issue. Patients come first, and to take care of them in that situation. But again, if you're in an elective procedure, you wanted to have some elective procedure done that is not life-threatening to you, and you're not vaccinated, your procedure could be delayed, because it depends on the surgeon and the people that work in that area as to whether they are willing to be exposed to a person in that situation. But so yes, there is some differences, ma'am.
Dr. Simmons, just like Mark, I have a lot of people in my family, relatives, who are not vaccinated. They've all had COVID, but they feel they don't want the vaccination. And, it's very difficult even convincing them that they need to have it. But I want to know more about the after effects. What are these after effects? How long are they going to be after effects, and what do people do?
The after effects of
COVID, having COVID.
having COVID.
Yes.
Now, when you have had COVID, your body has created antibodies to that virus, and so in some circumstances, there are people that claim that you may have as good or even better protection because of the having the COVID than if you had the shot. However, there is going to be some debate on that particular issue. So I'm just saying that you can be what you can have brain fog. That's one of the biggest problem. You're very tired. I had COVID right around Christmas time, and all of the plans that we had for Christmas had to be canceled because my family and I were isolated, and nobody went anywhere. But even though after a couple of weeks I was back at work, by the time I got in the afternoon in the operating room, I was dead dog tired, which was never the circumstances for me before. I was always, and so that can go on after COVID for quite a while. You can have also in my circumstances and in many people's circumstances, I lost 12 pounds when I had COVID. I do not recommend that as a diet plan, but I lost 12 pounds because you didn't feel like eating. You didn't feel like doing much of anything. And so that was, and many people talk about losing weight and so forth. But the residual effect that you can have as far as the brain fog is the one that I'm more concerned about. No one can explain exactly why some people can start having memory loss, and you seem like you're not your normal self. You can't get it together. That can go on for months after having.
Oh, really?
And you know what, Doctor? Whenever we have you on, it just seems like there's not enough time. There's so much. The information you share with us is wonderful, but we never have enough time to get everything we want out of you. But we'd like to thank you so much for taking the time out of your busy schedule to inform our viewing audience about the latest information on the COVID-19 virus and vaccination. We'd also like to thank all of you for tuning in, and remember, our live program airs the first Friday of every month at 6 o'clock. And remember to get vaccinated. And one more question before we go, if you can. Are we going to have to get a booster shot every 6 months? Just a yes or no answer.
I hope not.
Okay.
I hope not. No, okay. I don't think so.
All right. Thank you so much for coming on again. Alice, any last words?
Yeah, well, this was very informative to me. I did have one last question.
Yes, ma'am.
About the racism in the medical profession, and if we feel it or sense it or see it, how should it be handled? If you're a patient and you sense the racism, how should it be handled?
And unfortunately, we have to wrap up.
Is it wrap up time?
Sure, wrap up time. There's no longer any time. That's it.
Well,
we never have enough time.
Okay, I just wanted to let them know. Take a list with you of the things you want to discuss when you go to your doctors, and make sure that each things get answered. Because even if they're looking at their computers or they're not even looking at you or paying it, you need to get the answers you need. So you come up with a list. Otherwise, you might just forget what is important to you. But take a list and make sure they answer every question, regardless of the race and racism that might be involved. Thank you.
Thank you so very much. Everyone have a great day. Get vaccinated. And
thank you, Dr.
Stay tuned. Thank you.